Can everyone see my slides? They're good. Okay, good. Thanks, KP. All right. So less dense than Dr. Park's talk, so you guys can somewhat relax. My name is Chelsey. I'm an advanced practice provider at Children's Hospital, Colorado. I've been here since 2010, so long. And I've been doing ketogenic diet since then. So I'm going to be talking about the ketogenic diet and other diets that we offer and other diets that people follow. So let me start here. And if at any point someone can't see it, please holler because I'm going to have no idea. Okay, good stuff. Okay, so epilepsy diets. That's me. No disclosures, none at all. Not even one. All right, so this is kind of what we're going to talk about. Not that I kind of always hate these slides personally, because you'll figure out what we're going to talk about as we do, but I'm going to start with a case study. So this is, how does a child end up on ketogenic diet? How do you get there? So this is JR, we'll just give him those initials. He's 4 years old. His past medical history, this is relatively brief, of course, but birth history was pretty normal. Development, mom says early or advanced per mom, because all moms do. I'm definitely one of those. Past medical surgical history, unremarkable, RSV in the hospital overnight, but no big deal. Has an older brother who had 3 febrile seizures. Mom has migraines, because all moms do. How does a child end up on the ketogenic diet? Well, so October 2020, he had 3 convulsions in the setting of a fever. He wasn't started on medications yet. November 2020, he had his first afebrile seizure without a fever. It was unprovoked, 6 minutes, and his EEG is abnormal. He started at that point on topiramate or Topamax. In late November, he develops myoclonic seizures, those brief jerks, and absence seizures, those ones that we call like staring-like type seizures, and Topamax is increased. In December 2020, he developed drop seizures, and so he gets the addition of Depakote and now requires a soft padded helmet. January 2021, he starts having clusters of seizures. He's in the emergency room 3 times. January 2021, or late January 2021, Keppers added, having developmental or behavioral side effects. Parents are now reporting a lack of progression in school. This is how parents feel oftentimes. February 2021, he's now having multiple side effects. Topamax is stopped, Zonegran is switched. He's now on Keppra, Zonegran, and Depakote. His 24-hour EEG is consistent with myoclonic astatic epilepsy, also known casually as DUCE or DOSA syndrome, tomato. April 2021, he's still having clusters of seizures. May 2021, his parents are tired of medications and side effects, and they would like a different option. So I actually had a kid with DUCE syndrome when I was up at epilepsy camp to speak to this medication burden, and she took medications 3 times a day. And her midday pill regime, I actually had to do her medications in a separate room because I became so flustered, but she had 14 pills just at lunch. And it was then that I was like, now I get it. I don't think you really get it till you see it. So who is refractory? So we often use the ketogenic diet for people that are often refractory to seizures or have seizures that are difficult to control. This has probably been reviewed, so I'm going to just touch on it briefly. So about 47% of kids, this comes from a 2000 study, about 47% of kids will be seizure-free after the first drug. If you scooch that over, an additional 13% on top of that will be seizure-free with the next drug, and then a small proportion will actually respond to a third or multiple medications. That means 36% of kids will have a hard time controlling their seizures with medications alone. So who is ideal for the ketogenic diet? This data. So I'm going to say outright that anything in my slide that doesn't have a source cited at the time is coming from the 2018 consensus statement that I have at the end of my slide. So any data that comes in between them that's not directly has a reference on it, this is where it's coming from. So these are people that are felt to be more than 70% beneficial, higher than the average basically rate of about 50% response rate to the ketogenic diet. So People who we find to be specifically good responders to the ketogenic diet include Angelman syndrome, mitochondrial disorders, Dravet syndrome, DUCE syndrome. You may remember our little buddy from the previous slides. GLUT1 deficiency syndrome. So this is actually the standard of care for that. FIRES, or people who have seizures that meet a certain type of status epilepticus related to fever syndrome, formula-fed kids, infantile spasms, Ohtahara syndrome, PDH, superrefractory status epilepticus, and tuberous sclerosis. And who are other candidates? So these are people who are felt to be around 50th percentile, not particularly higher than the 50th percentile noted, or for 50% reduction in seizures, is CDKL5 encephalopathy, childhood absence epilepsy, cortical malformations, epilepsy of infancy with migrating focal seizures, ESES, juvenile myoclonic epilepsy, Lennox-Gastaut syndrome, and so on and so forth. Other syndromes that are a little bit less common. So what is the history? So there's actually a quote. I had to find, it was very hard to find. I've always told people there's a quote about it in the Bible, and I never actually went to go find it until now, and I found it. And so this is the quote: "Lord, have mercy on my son, for he is an epileptic." This is from Hippocrates' New Testament, Matthew 17:14-21. He often falls into he suffers severely. He's an epileptic. He often falls into the fire and into the water. So I brought him to you, disciples, but they could not cure him. So Jesus said to them, "Move from here to there, and it will move. This kind does not go out except by prayer and fasting." So fasting is the key part of this, that when children, well, people were fasted, when you take in no calories, you'll burn your own body fat. And when you're breaking down only fat as your primary source of energy, you will start to make ketones. So in the early 1900s, it was discovered that a high-fat diet can mimic ketosis. In the mid-1900s, the ketogenic diet was reintroduced at Johns Hopkins. We don't entirely know. I didn't put a slide in here about what the exact mechanism of action, because you can get real into the weeds. I will say that is probably a multitude of physiological actions that produce the benefits of the ketogenic diet. We don't really know. I will say, as opposed to the medications, oftentimes you'll increase the medication, you can see a change in seizures maybe in a day or two, sometimes a week or so. That we sometimes don't see benefits from the ketogenic diet for months at a time. And that's probably because it's affecting a variety of different long-term systems in your body. I won't get into it unless people really want me to at the end, but we'll go on to the next slide. So this is, I wonder if I can, what are the odds I can play this? I'm gonna, here we go. So this graph here that you see is the number of ketogenic diet studies that were published over time. So you can kind of see as soon as basically the Charlie Foundation was created based on Charlie Abrams. Jim Abrams, who was a major director in the 90s, his son had DUCE syndrome, and he kind of pushed Johns Hopkins to start this diet for them based on this video, which I'm gonna try real hard, not based on this video, but this is an excerpt. Hopefully everyone can, I'm hoping it plays. Here we go. Can you hear it?
So here's what happened. Charlie got sick with horrible epilepsy. He failed all the available drugs.
We could hear it.
And
Okay.
brain surgery didn't work to stop his seizures. And eventually, we found the ketogenic diet in the library. We put Charlie on the ketogenic diet and seizures went away. When something like that happens to a family, there's this initial euphoria, and then all of a sudden you step back and you realize there's a world epilepsy population of over 50 million people. Most of those people start having their seizures as children, and only a small fraction ever find out about diet therapy for epilepsy. And I can tell you from our experience, almost as horrible as watching what Charlie went through was figuring out that 90% of what happened to him was unnecessary. So Nancy and I figured that we had to do something about trying to raise awareness of the ketogenic diet.
You had some knowledge that this diet was probably working back at Johns Hopkins, and yet you dissuaded the Abrams from attempting it. How come? Well, because I don't think we had exhausted all of the medical approaches yet. There were actually still other medications that we hadn't tried yet.
There's something wrong here. There's something really, really, really wrong. I bring my kid to you people for help, and all you do is make him sicker. You give him one drug, and then he needs another drug to cure him of the first one. And then he needs another drug to take away the side effects of that one. And another one, and another one, and another one. I mean, he has had a rash, swollen glands, a fever, constipation, hemorrhoids, bleeding gums, and he acts like a drunk, a zombie, a psycho. And it's not because of his sickness. It's because of your cure.
So why are modern doctors ignoring this diet? Charlie's own doctor has a surprising answer.
There's no big drug company behind the ketogenic diet, and there probably can never be unless somebody starts marketing sausage and eggs with cream sauce on it as a drug. You're saying that in a sense, one of the reasons that the ketogenic diet is not popular at this point is because there's not a big drug company behind it selling it to the doctors. I think that's probably true. I hate to say that, but I think it's probably true.
Johns Hopkins, they took 58 of the sickest kids, put them on the ketogenic diet, and almost a third of them had their seizures go away.
Second day of the diet, her myoclonic stopped. And we didn't even talk about it.
So 24 hours in, and my mom came in the hospital. I'm so excited. I said to her, "You only had 5." And she was so excited because we went down from 100 whatever to 5. It was phenomenal because the school was saying he was so connected, he was learning, he was engaging, and he was communicating. I'm pushing the button, to call the nurse, and I'm like bawling, I'm crying. I'm like, "Hey, you guys gotta come and see this right now." And they come running in like, "What's going on? What's going on?" I said, "He just got up and went to the bathroom." "Oh, what happened?" I said, "Well, he's never done that before. This is a miracle." It's like too good to hope for. So he had 5. The next day, I think he had 2. And the next day he had 0.
Too big, too swing.
Oops. Oh gosh, what did I do? I did it. Sure. Whew. Okay. I'm not crying, you're crying. Okay. Let's get back to it. Here we go. Okay. So yeah. So as you can tell, obviously I took that graph from them about the ketogenic diet studies. So it was, I think, early 90s that this really started to explode. So let's talk about
You're in
what,
presenter, Chelsey, you're in presenter mode.
oh, what does that mean? Hold on. Oh God. Oh, okay.
Can you see up there in the corner?
Hold on. Wait. Oh yeah, I switched
Just
screens. Is anyone offended with
do end the slideshow and then try to restart it from the current slide.
Okay. Oh gosh, that's yours.
Oopsies.
There we go. Better?
Still.
Gosh darn.
How about clicking on that slide, the little slide icon in the bottom? The little projection screen next to it.
No, no. No, no. This one. No, 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 no.
Oop, no.
That was the wrong move. Wonder if I think so.
Never, don't worry about it.
Okay.
Don't worry about it.
Is this better?
Now we can't see it at all.
Really? All right.
Don't worry about it.
Okay. I'm gonna have to end my slide. And I think it's like it's on one of my screens and show. Okay, well, sorry guys. I wish I.
No, I'm sorry. I'm sorry I even brought it up.
Okay. All right, so presenter mode. Sorry, everybody. Classic ketogenic diet so what is the ketogenic diet? So it is a high fat, adequate protein, limited carbohydrates. So typically how we design the ketogenic diet is we'll take a keto, our dietitian will look at a keto and say, okay, they are X amount of weight, they're this age, their protein goal is this. And then we basically kind of design the diet around them and what our goal for the ratio is. So fat on this diet comprises about 80 to 90% of the calories, usually provided from butter, oil, heavy whipping cream, oftentimes mayonnaise. Carbohydrates tend to make up the rest. So you're going to hear about, and I don't think I address it very well, but you're going to hear about this idea of ratios. So you're going to hear the ketogenic diet, the highest, like 100 mile an hour, the highest kind of ratio you do is about 4 to 1. That's 4 parts fat compared to 1 part. And that 1 part is a combination of protein plus carbohydrates. So 4 to 1 is like going 100 miles an hour. If you bring it down a little bit, if you're going 75 miles an hour on the diet, it'd be like a 3 to 1. 50 miles an hour would be a 2 to 1. And then a 1 to 1 would be like 25 miles an hour. So you're gonna, if throughout the rest of the talk, and probably if you go to Google this or look at other groups, you're gonna see this idea of a ratio, and that's just parts fat to parts non-fat. And that non-fat is protein plus carbohydrates. Efficacy of the ketogenic diet. So about 40%, so it depends on the study you read, but it's like 50% of kids had more than around a 50% reduction in seizures compared to about 6% of controls. A large portion of kids, 80% of children who are seizure-free on the ketogenic diet will remain that way after diet is discontinued. The risk of recurrence of seizures is higher for kids with abnormal EEGs or cortical brain malformations or lesional epilepsies. In a multi-center study from Argentina, seizures recurred in 25% of those who were seizure-free and stopped the diet. Many of these kiddos had brain lesions, EEG abnormalities. So that's just kind of supporting that notion as well. This is a picture of the classic ketogenic diet. This is 90% fat. The remaining about 10% comes up from protein and carbohydrates. This typical meal plan here is a typical meal plan for an 8-year-old or a 2-year-old, sorry. Breakfast is about 2 ounces of heavy whipping cream, ½ ounce bacon, ½ ounce apple. Lunch might be, again, 2 ounces of heavy whipping cream, 1/3 ounce of cheese, 1/3 ounces of ham. Strawberry. Snack is 1 macadamia nut or 3 black olives. Dinner, again, would be cream, chicken, butter, green peppers. Now, we used to limit fluids. So it used to be an old idea that we would limit fluids on the ketogenic diet. And that's because at that time, I believe many, many years ago, we were measuring urine ketone concentrations as a marker of ketosis. And if you are dehydrated, the density of those ketones in your urine would be higher. So I think people thought that if you limited your fluid intake, then you would be more ketotic. But now we just know that based on, now we do blood draws, that how hydrated you are actually doesn't affect ketosis and actually helps mitigate a lot of the side effects. So we don't fluid restrict at all. We do unlimited water, Crystal Light, sugar-free Kool-Aid, that type of thing. This is a classic ketogenic diet meal. So this would be something like, this would be like a day 1 type meal. So what you're not seeing here is the mayonnaise or butter. So you can actually cook the mayonnaise and the butter in the eggs. Some kids get real egg fatigued on the diet because eggs are just great for hiding a lot of things, fat particularly, obviously. And then I think you can get like 10 blueberries. This might be a little bit too many berries, but I think you can get 10 blueberries for about 1 gram of carbs. So this would be a typical like day 1 type meal, kind of simple ingredients. So on the ketogenic diet, compared to the modified Atkins diet, which we're going to talk about later, on the ketogenic diet, everything is weighed and measured on a gram scale. So you'll see that I have grams written out there. We often provide, at our institution, we often provide a gram scale. You can also get a gram scale from some of the ketogenic diet formula companies. So this would be a typical meal for probably a little kid. This would be like an advanced one. This would be like when people start doing this, I know you're fancy. So this would be, this is a keto pancake. It has 30 grams of macadamia nuts roasted, which is, you know, extra fancy. 28 grams of eggs. You can do the vanilla extract. I always recommend some stevia and things. I probably would tell someone to put stevia in this, but that's just me. And then 6 grams of pecan or macadamia nut oil. So you would have to like blend this all together in a food processor. And we actually have, there are several companies that make a 0 carb, 0 calorie syrup, one of those brands being Walden Farms. It's basically free in common volume. So this would be this is actually, I believe, a 4-to-1 ratio as well, made up of mainly macadamia nuts and eggs. On the classic ketogenic diet, the diet is actually inadequate in many vitamins and minerals and often needs supplementation. What's kind of stinks about this, you know, there's ups and downs, right? So you can get a 50% reduction in your seizures. That's awesome. There are certain syndromes that are really amenable to the diet. But I will say that the downsides, and there are several, is that it can complicate your care in some ways. So a lot of people go on this diet to kind of get off pills and tablets and things because their day is kind of complicated. I will say this actually kind of complicates kids' care a little bit. Could be worth it, very much often is. But you will often require multivitamin, carnitine, calcium D supplementation, bicarbonate supplementation. Some kids need selenium and phosphorus supplementation. So you will have a little bit more of like this complicated vitamin and mineral kind of regime that we put you on. Common deficiencies include carnitine, zinc, selenium, magnesium. Phosphorus is probably the most common deficiency. Actually, I would say fiber, which is not something you measure. Fiber is very deficient on this diet, as you imagine. Again, we do not fluid restrict anymore. This slide is about both modified Atkins and ketogenic diet side effects. So I will say that we find more side effects on keto than modified Atkins. So a lot of these side effects are certainly much worse and much things we worry about a little bit more, the higher degree of your ratio or how restrictive your diet is. So I would say possible side effects include kidney stones. So it's around the same incidence rate as other medications like Topamax and Zonegran. It's around 5% of our kids will get kidney stones, but we do try to mitigate or test for that. We will test the urine for crystals. We'll test the urine calcium creatinine ratio, which kind of tells us your risk of kidney stones. We'll look at hydration of the urine as well. Constipation, as you imagine, this diet is nearly void of most fiber. So we use a lot of Miralax. We'll use a lot of unsweetened aloe vera juice. We'll use chia seeds, smooth move tea, magnesium. We have Milk of Mag. We have a lot of tricks and tips, but I will say I have a handful of kids. It's not common, but I have a handful of kids who have other developmental delays who do end up on this diet and end up on a daily suppository. That's not our goal, but lots of kids will have no problems whatsoever. Some kids, this always gets a laugh out of the dietitian, but some kids will actually have to take in so much oil that, for lack of a better term, it kind of like greases the chute, and kids actually have very smooth and very frequent bowel movements. So that sometimes is mitigated just by being on the diet. Elevated lipids, we actually will find that most kids will have an elevated lipid parameter, like elevated lipid parameters up until about 22 months to 24 months on the diet. And then they start to look great. They often will look kind of ideal. And I'm not entirely sure what drives that. I'm very interested. I did a poster on it, but I still have yet to really understand the physiology behind that. Decreased linear growth, that just means that kids can get a little shorter with time. That usually, again, happens after kids have been on the diet for about 2 years. So typically we'll see someone that'll be at the 50th percentile for height. And then around 2 years, we'll look and be like, now they're at the 30th percentile. If diet is stopped, they will tend to pop back up to the 50th percentile. My suspicion, what drives that is the fact that we do meet protein needs, but the average person on the diet will often exceed protein needs because proteins are often delicious. So I think it's like probably on days where they don't feel well or you're coming up short on your protein, I think that might have something to do with that. But ultimately, if kiddos come off diet, they will go back up. But a lot of people kind of don't care if their kid goes from the 50th to the 30th percentile in height if their seizures are controlled. Trace vitamin and mineral deficiencies. Now that can be serious. So there are several documented deficiencies that can have a lot of pretty profound impacts. So selenium deficiency can cause prolonged QT syndrome. which there are documented deaths. It's rare. There are more case reports than big patient populations, but you can have selenium deficiencies. That is one of those labs that we test. We do supplement for that as well. Acidosis. So ketones themselves are acids. And if anyone remembers the pH scale, acids, we like to run about 7.4, ketones are acids. And so when we are acidotic and we have acid in our blood, we tend to feel pretty lousy. We get lethargic, we want to throw up. You kind of don't want to eat, which can, again, sometimes is like a self-defeating prophecy, and that we try to get kids to eat this fat, but they don't really feel good. So it can get a little bit hard early on, but we persevere. Weight loss can happen, and again, so can weight gain. So on classic ketogenic diet, we do take an educated guess on their calories, but sometimes it's not always accurate. So we'll have parents call us 2 weeks in and be like, they are starving. And so we'll add in another snack. We'll increase meals by 10%. Weight loss is a very big concern on the modified Atkins diet, because when we tell people, if you remember, on the ketogenic diet, we weigh and measure all those food ingredients. On the ketogenic diet, when we say, 40 grams of fat, parents, it's a lot of fat. It's not a couple tablespoons. It's like a quarter cup or a half cup of things like mayonnaise and oil and stuff, and softened butter. So on modified Atkins, people kind of don't really understand what we mean by really push the fat to thwart the weight loss. So you will see more weight loss on modified Atkins. Worsening reflux. So this is a very fatty food. If you eat a very fatty meal, we know that it kind of sticks around with you longer. In kids that maybe have low tone or already suffer with reflux, this tends to be a big one for them. In addition to this, something that's not on there is low motility. So kids who maybe have gastroparesis or like low motility of their gut in general because of their underlying other neurologic condition, that will get worse as well. So other reported side effects that are rare but serious are osteopenia or fractures. We will get a lot of our kids actually come onto this diet already with low bone density. And that's often because a good portion of our population is wheelchair bound or has been on anticonvulsants for a long period of time. Anemia is rare. I actually don't think I've seen that in 11 years, but it's listed as a potential side effects. And I think that's when you're not fully supplemented in iron. Prolonged QT syndrome or cardiomyopathy, that's again with those trace vitamin and mineral deficiencies. Pancreatitis, so that the pancreas is the only organ in the body that can break down fat when you eat too high, or not too high, because this is appropriately high. When you eat a high fat diet, it can ask too much of your pancreas and it can become inflamed. Now, I have not had a child pass away from pancreatitis, but I think I see this one out of all those things on there. This is the one I probably see the most, maybe like one a year or one every other year. Oftentimes when kids on ketogenic diet present with acute pancreatitis, they're often sick with other things. I think 2 times in 11 years, I've seen a kid just like look good on ketogenic diet, didn't have anything else going on, got pancreatitis. We will stop the diet cold turkey in that circumstance. A lot of times the emergency room, like I actually got called on a Friday driving up to the mountains when no one else from keto was on, and nurses didn't really know what to do. And someone had presented with pancreatitis at an outside hospital. And I said, give them a popsicle and resume regular diet. Like you just stop diet then, and you then work with your neurologist about what to do for seizure control. We don't often try to persevere through that one. Low protein, that's relatively rare, and that's probably just related to a high ratio that may be neglecting protein needs in effort to maintain ketosis or push ketosis. Leukopenia, so this is, again, this comes with a lot of caveats. So I've actually got a poster coming up at the upcoming conference, and this has been kind of well established that leukopenia can occur in about 15% of kids, usually around 2 years into the diet. There's a lot of confounding factors on this though, because a lot of the anti-seizure drugs that our kids are on do list leukopenia as a rare but real side effect. And so I would call leukopenia on diet somewhat rare and real, but it doesn't happen, except for like 2 years in again. What the mechanism is behind that, I'm not sure, but it can happen. How do you start the diet? So like you or your child are intractable, you're interested in this. What do you do? So our system is pretty similar to other institutions. So I'll tell you how kind of we do it. You would talk to your epileptologist and you would say, I want to talk about that. They would decide if you're an appropriate candidate and send you to our Keto Clinic. In our Keto Clinic is made up of basically 2 people. one advanced practice provider, which is a nurse practitioner or PA like myself, and a dietitian. We will talk through, we'll evaluate the current social situation. So do you go to school? Are you split between households? Does your kiddo get their own snacks? Do they, can you send meals? So we've actually had to work with a local school district up in Adams County for a kid who does have to get school meals. And we've had to teach the lunch person there, who's a dream, how to do this, and she's done awesome. But then we will also check a variety of labs. So there are rare disorders of fatty acid metabolism, which I didn't list here. I've only found it once in 11 years where we've actually had to, we actually fixed this disorder of fatty acid metabolism. Their seizures went away, but it's relatively rare. But we will do some labs to rule out disorders of fatty acid metabolism, as well as check your baseline nutritional labs. I used to fast kids for their first lab, but it often made, when you're fasting, you also get ketotic a little bit. And so it makes your carnitine profile and some of your serum amino acids look kind of funny. So I told people, I just want a non-fasting lipid panel. Don't be scared when you see your lipid panel. So in case you're wondering why I send a bunch of non-fasting kids to get their lipid panels, that is why. So on the ketogenic diet, the diet is incredibly sensitive to carbohydrates. When I'm talking sensitive, things like lotions and oral products, and especially medications. If anyone's ever given their kids liquid medications, the bottles are often sticky, especially if you spill it, then the whole shelf in your medicine cabinet is garbage now. So that stickiness is the sugar that is used to sweeten kids' medications to make it palatable. We can't have that sugar, so we often have to switch kids' medications to tablets and capsules. So, and here is why. This is a comparison, this chart is a comparison of the carbohydrates between tablets and liquids. I think, so Keppra doesn't really look, so for a 250 milligram tablet, 250 milligram capsule, there is 0 carbs. Per ml of Keppra, there are 200 milligrams of carbohydrates. So if you had 5 mLs, that would be 1 gram of carbohydrate, which means you don't get now 10 blueberries. So for us, we'd say, you really want some of those phytonutrients from those plant-based foods. So let's actually really try to get you, and that also makes it much more palatable when you can have 2 tablespoons of banana or 10 blueberries or a cup of spinach. So we do really try to do the best we can. There are rare cases where we say we can't really get the kiddo to take liquids, so we actually just get fewer carbs. Depakote's my favorite. You guys should see, amoxicillin. Amoxicillin is 3 grams of carbs per ml. The thing is it's basically honey incarnate. It's crazy. Depakote per 1 ml of solution is almost an entire gram of carbohydrate per 1 ml. It is impossible to keep Depakote on the diet, but with a sprinkle capsule, 0 grams of carbs. So you will see us switch a lot of liquids to tablets or capsules, not chewables. Chewables also are sweetened. So how do you start diet? So about 80% of centers, based on that 2018 consensus that I will cite at the end, they will begin a classic ketogenic diet in the hospital. So a 3-to-1 or a 4-to-1 ratio often begins in the hospital. Why do we do an admission? And again, I kind of alluded to the fact that the acidosis that's associated with the diet makes you feel lousy. It makes you want to throw up sometimes. You don't want to eat. Sometimes there was actually a study from 2017, I believe, that I haven't referenced in here, but I use it a lot when I talk to families. In 2017, they, Kosef, of course, et al. Looked at how often kids require acute intervention when they're initiated with the ketogenic diet, and what are features of that patient population that tell me okay, you're more likely to be that type of kid. They looked at age, they looked at the way in which the kiddo ate, they looked at other medications. Medications didn't matter. So anything that also causes acidosis, like Topamax and Zonogram, didn't affect that statistically. The manner in which you ate actually didn't affect it. It was age. It is the age that my current child is now. 3-year-olds are really stubborn and very difficult to get them to eat. So it's about 18 months to 3 years old tend to have the highest frequency in which you require IV intervention. And that IV intervention, again, is either fluids, it is bicarbonate, It's anti-nausea medications. So those are the kids that actually require the most amount of like interventions because they're just so stubborn. The admission also is very helpful for, that's actually when we do a lot of the teaching. So you can we round on those kids multiple times a day. During that initiation, we'll also do daily labs and let you know how how acidotic the kid is, how they're progressing in their ketosis. It can actually be started as an outpatient basis. And of course, COVID forced our hand to do that quite a bit more. Now we're probably like 50-50, starting classic ketogenic diet at home and ketogenic diet in the hospital. I think things that tell me to do it in the hospital are, again, kids with a lot of other co-occurring medical conditions. If they've had a history of really bad formula intolerance or GERD or gastroparesis, I might start those kids in the hospital at 18 months to 3 years, the stubborn age. Although I have being said, I don't see that the stubborn is ending past 3, but that stubborn age will start in the hospital where they can just refuse food and they're just good at it. We will start in the hospital, but G-tube fed kids who are a little bit older, who don't have any history of formula intolerance, we might start those kids at home. Or older kids or people who live really close to the hospital, we might start those at home depending on, or we've also on the other side of that, kids that are, especially in COVID, that are very sick and we want to keep out of the hospital, we might start them at home, but we'll start them at a lower ratio. So we'll start them at like a 2-to-1 and see in a month, and we'll see if it's helpful. And then at the next subsequent visits, we might go slowly up. So a recent European consensus-based guideline recommends hospitaling any infant. That's another thing I forgot to say. Any infant under 12 months needs to be hospitalized for the classic ketogenic diet. So again, this is when they're admitted. We usually admit on a Monday because most people, we have kind of a skeleton crew on the weekends. So they come in on a Monday. We do labs every day. We check urine ketones every day. They start getting pretty irritable and hungry come day 2. Day 1 at our hospital, we offer only a ketogenic formula by mouth. So we don't really eat food. We just drink KetoCal or other ketogenic formulas by mouth. We offer, again, ad-lib calorie-free beverages. Constipation starts to become an issue. So sometimes we are talking about Miralax or doing suppositories. Because again, there's a lot of poop talk on this and I can't avoid it. I'm sorry. But if you come in constipated and you're clogged and you're constipated, sometimes when you're so constipated, you actually have a lack of appetite. So if kiddos haven't pooped in a day or 2, we start working on that pretty quickly. Acidosis and electrolyte imbalance happens as well. Nausea, again, hypoglycemia, that's rare. So I will also say that we accept, in general, if a kiddo average person, like carb eating fool like myself, is fasting, my glucose might be 65. That's a normal fasting glucose. On kids on the ketogenic diet, a normal fasting glucose for them truly might be 45. And that makes a lot of medical providers who aren't familiar with the ketogenic diet very nervous. That does not make us nervous. We start worrying if it's under 40, and we usually give a little bit of juice, or if they haven't eaten yet, we'll tell them to eat their first meal. Because again, there are carbohydrates in every meal. Usually, depending on the diet you're on, 3 to 5 grams of carbohydrates per meal. So just eating your typical breakfast may actually thwart that hypoglycemia. We don't try not to, but if we can avoid giving them juice and they look good, we'll just tell them to eat their food. So we don't really have a criteria for discharge. It just basically, one, kid has to be medically stable. Glucoses, and again, I say 60s, but it can be 50s and that's fine. That's actually really, really common. Their bicarb has to be normal or on the mend, vomiting is better, and they're accepting the diet. That really, I would say education completed and accepting the diet and medically stable are about it. There aren't really very complex criteria for discharge. So if your child has a G-tube, you might see these cans and ingredients very frequently. So we do have a soy-based and we have a dairy-based. We also can do like an elemental keto, which gets a little bit harder and not really palatable by mouth, I will say. It's kind of soy or dairy if the child ever wants to taste it. I have a mom, it like dawned on me, like this year, I had a mom that was like, can we have the flavored keto cow? And I was like, why? Your kiddo eats their G-tube. And she's like, when they burp, it smells like the formula. And I can only imagine they taste it. And I was like, oh my gosh, that's so true. So now we're actually like, since that, 11 years in, well, I don't know why I look at my watch for that because it's not the time, but 11 years in, I just finally was like, maybe we should start giving kids who are G2 fed some of those flavors because it must taste terrible after you burp if it's not flavored. So dietitians will look when we have G2 fed kids. We will work with a local like medical supply company and have these formulas delivered to your house. The hard part that we find a lot is that people who start diet, maybe it doesn't work for them. They have a lot of these supplies on hand. We can't accept them back, neither can the formula company. So we do actually encourage families to reach out to other families who have kids on the ketogenic diet and offer to donate them. We can't accept them, unfortunately. But again, so back to like the formula basis of this is that, lots of kids, formula intolerance may occur due to high fat diet and poor gastric emptying. So that is something that we very much see on the diet. So if any kid has a G tube and maybe their formula ran and they have a pump and they formula ran at 200 mLs an hour over 40 minutes before, they might leave and have the diet being like 150 mLs now on for an hour, or they often have to tinker it a little bit so that it's going slower and then kind of work back towards what their previous like rate and goal was before. So kids on diet, so we can do babies. So let's say an infant starts diet, they're all formula fed, they now want to start eating. We can do that. We absolutely can do that. And it's not hard. So for infants, because they have such high protein needs, and they mask their symptoms of acidosis somewhat better than older kids, we will start them at a 3-to-1. We rarely go above, except for in cases of metabolic conditions that require high ketosis levels like PDH and GLUT1. This is a picture, you can't tell, but this is applesauce and butter in that jar. I don't know why I just didn't put applesauce in there, but so it usually is like, 10 grams of butter and 5 grams of applesauce, and you mix that together, and that can be a baby food step 1 or step 2, really. So it's really just kind of a simple food plus butter or fat. It doesn't always have to be butter. It can be mayonnaise. It can be oil for anyone that's dairy intolerant. So, and then often we really don't calorie restrict in infants. Bottles are just given ad lib. Rarely have we had just like the Michelin baby and been like, let's cut back a bottle, but it's still, it's adorable. So follow up. So there in that video, one of the women said something that I like is not my favorite. She was like, on day 2, we were seizure free. And while that does happen, and here's a statistic, 75% of children will respond to the diet in 14 days. That means 25% won't, and they may take a couple months to respond. So we really tried to you will see that adage a lot because 3/4 of people will have that experience, but it's not the experience for everyone. And I do recommend that everyone stays on the diet for at least 2 to 3 months. Another study has shown that seizure freedom, although most likely to happen in the first few months, may occur as late as 18 months into the diet. So for kiddos who especially are amenable, have one of those really amenable diagnoses like DO syndrome or Dravet syndrome, we will say if they're better, let's stick to it because it really may take 18 months. We do regular follow-ups. So no matter what diet you're on, we ask you that you come in at 1 month after you start the diet, then every 3 months for about 2 years. And then after that, it's about 6 months. If you live very far away, we'll start to get a little bit more flexible around year 1, but because there's a lot of calorie adjustments, most of the lab changes are going to happen by visit 1, 2, or 3. At each visit, we check growth parameters. We do fasting labs every 6 months. Now we do fasting labs. Before I didn't. We, of course, just adjust calorie, water, your calcium and vitamin D and selenium needs change as kids get older. We will start doing bone densities for kids actually age over 5. I apologize because there aren't normal values for kids under 4 because under 4, they're just mostly just giant gelatinous growth plates before them. So we don't have normal values under the age of 5. So alternative diets. This is a modified Atkins diet. So this is when someone like Kourtney Kardashian says she's on a ketogenic diet, she's probably on a very loose version about what I'm about to talk about. So the modified Atkins diet is a less restrictive than the classic ketogenic diet. If you remember the ketogenic diet, everything is weighed and measured on a gram scale. In little kids, we'll often say 1 to 2 snacks because we don't want to be that rigid because for my kids, it would basically be like a day of snacks, but we will say 1 to 2 snacks per day on ketogenic diet. So it's calorie controlled, but not to the calorie. On the modified Atkins diet, instead of weighing and measuring your food on a gram scale, you're actually counting carbohydrates in common volumes, cups, tablespoons, numbers of blueberries, which your kids on the ketogenic diet when you're counting blueberries. The typical ketogenic, like modified Atkins diet, is about 10 to 20 grams of carbohydrates. To put that in perspective, and that's in a day. So that's about 3 grams of carbs per meal, 1 gram of carb per snack. One apple, depending on the size of the apple, has about 15 grams of carbohydrates. So a glass of milk, an 8-ounce glass of milk, has anywhere from 12 to 15 grams of carbohydrate, depending on the fat content of the milk. So it is incredibly restrictive. Most of your carbohydrates, we recommend that most of your carbohydrates come from some of those plant-based foods to get all those phytonutrients that are probably very important to your health. We do unlimited fats and protein, so kids can have as many zero carb foods as they want. Chicken, pepperoni, eggs, really just any simple meat. We watch out for fillers. So I believe the McDonald's like burger patty is like 85% meat. And I'm like, what's the other 15%? So we do recommend that people, it does allow for eating out a little bit better. But it still requires that you actually look on that like restaurant's website and like look for what their ingredients like is in their patties and things. You can actually like do keto, like all fast food if you really want, but obviously breaded chicken, fillers and things don't work. Weight loss is an issue. And again, that's because people don't recognize when we say fat, like how much fat we're talking about in order to thwart that. We usually recommend about 2 tablespoons of fat at each meal, 1 tablespoon at each snack, depending on the age of the child. And that's, 2 tablespoons of mayonnaise, 2 tablespoons of heavy whipping cream, 2 tablespoons of softened butter. The plus side a lot of people don't recognize is that spices and things like hot sauce are allowed on the diet. So you could do a hot sauce and mayonnaise and make it a dip or something. So you can, it's not just mayonnaise and meat, but according to this picture, it obviously is. So this is kind of a plate picture of the modified Atkins diet. There's a very good modified Atkins taco salad that's really, really common on the modified Atkins diet. So it's about 65% fat. That's if you're pushing fat, and unlimited protein. One alternative diet, which is used really, really commonly in the Angelman syndrome population, is the low glycemic index diet. This is much less restrictive than the classic ketogenic diet. We actually don't initiate anyone at our hospital on this. We will provide, if patients want to, we will provide them handouts on this. And it has some benefit, but again, we do recommend checking labs at least every like 6 months. And a good multivitamin and calcium and vitamin D are recommended. You are allowed up to 50 grams of carbohydrates. We usually do recommend checking ketosis because some kids are just really good ketone producers and you might want to check labs more often if that's the case. But we have seen kids that are ketotic at 50 grams of carbohydrates because I think in that case, parents push fat, like a cup of mayonnaise, a quarter cup of mayonnaise at each meal. So this is something that we don't initiate. This is usually a step down if someone is weaning off a diet slowly, or this is managed kind of separately in a different clinic with the Angelman group, and it's quite a bit less restrictive. And it requires that you use carbohydrates only from low glycemic index foods. Glycemic index is basically a fancy term for carbohydrate containing foods that are high in fiber to kind of prolong or like help with the euglycemia. This is a broad table kind of comparing them. Now, I didn't get into the weeds. I could get real into the weeds if you want to with MCT oil diet, but I'm not going to because, no one wants to fall asleep today, right now. So the classic ketogenic diet is 90% fat, 6% protein, 4% carbs. You lower the ratio, like when we were talking about with the infants, now they're 87% fat. They do require more protein. They have 3% carbs. And if you go all the way down to the modified Atkins diet, it's 65% fat, 30% protein, 3 to 6% carbohydrates. Other products that we use, so I used to keep, I mixed and matched. I made this lecture for you guys, but I mixed and matched this with other lectures I had, and on this was like shaving cream, and I was like, why do I have a slide about shaving cream at a pediatric hospital? But anyways, so there are other things that we use on a daily basis that can contain carbohydrates. So moisturizers. So we have a saying in keto: it smells delicious, be suspicious. If it smells sweet, it may contain carbohydrates. And our skin, which is our integumentary system, is the largest organ in the body. If you put carbohydrates on your skin, you actually can absorb enough to fall out of ketosis. Same with oral hygiene products, same with chapstick and things like that. So there's all sorts of things that we will give people recommendations for, like common products. They're really not crazy. It's nothing that you can't find, which is a double negative. Everything you can find at King Soopers or Walmart. They're just basically like fragrance-free or hypoallergenic or no added flavors type stuff, really simple stuff. Do I really get like crazy about shampoos? Not really. And, you know, I used to have like eye drops on here. I just like blanket decided that anything less than like the size of a quarter that goes on your body, I don't need to worry about it unless it's like honey. But for the most part, like eye drops and like a little, if you have like a little granuloma or a little rash or something like that on some spot, I don't mind those things. So I don't worry about those. But all over products, sunscreens, lotions, and mouth oral hygiene products can contain carbohydrates. And these are basically, if I cited anything other than this, I cited it on the slides, but I did rely heavily on the 2018 consensus. That was, a big paper a few years ago. And look at that, KPI caught us up on time. Okay. Should I hang around for questions?
I think we have, we're on time. I think we have about a half an hour before our next speaker is scheduled to present. And I think if there are questions, we would be happy to take those. If not, then I think we may log off and have Lauren play our filler video, which has some information about Children's Hospital Colorado. So anyone with a question is welcome to put it into the chat and we can look at it and see. Who says Emily C? Wow. Modified Atkins at Hopkins, one of our listeners. That's excellent. I'm glad it was helpful for you. We do, I don't know, Chelsey, if you want to speak to this, we are seeing this to be used more often in children, adolescents, and adults with refractory epilepsy. And at one point in time, at one point in time, had a clinic with our adult colleagues. Do you want to speak to that a little bit, Chelsey?
Well, yeah, right before COVID, we had a combo clinic where we would have kids who have been on diet in our institution for a while, meet the epileptologist there, have a face to then go over there to and have a point of contact. But like COVID hit and like that was a disaster for lots of things. So that is not happening anymore. And plus that epileptologist has left that hospital, but I would love to restart that someday. But it is that transition of care. Previously, our affiliated university only did modified Atkins on adults, but now they actually are doing keto. They have a pretty big sized team, and they've been a good resource too. So we have had no issues transitioning anyone on full keto over there.
How it was when I did it, I was just out of high school, and my mother had that, where you said that video, my mother had seen about that. And I'd already had one brain surgery at Johns Hopkins, and I'd been on most of the medications that were released at that time in the studies for them at Johns Hopkins. And Dr. Freeman, here's a picture of him and me.
John Freeman, I love him.
And here's where he signed my book. First on the
look at you.
Not our last.
Wow, look
And
at that. Oh,
it's the book my mom read.
great.
She highlighted throughout it, everything,
Yeah,
and stuff.
You
And
have a good mom, a good
I know.
mom.
Yes,
yeah, but you're
and
basically a celebrity in this group.
so I had
Yeah,
to,
in our circle, you're
I
a
know.
celebrity.
I kind of want to meet you now. Yeah.
and I had to fax them every week what I ate, what I drank, how much exercise, and how you were mentioning.
Wow.
I mean, the fluid intake is not that. And I know I was on
Yeah.
carbohydrates a day on it, and I had to still use a gram scale because I was in between, like the Atkins
Yeah.
diet and the
Right.
keto diet.
Right.
It was something
Wow.
learning that, and I learned if it ends in os or tall or any of that, it's sugar. I was only allowed
That's exactly right.
sweet 10 was
Yeah,
all
I think
was
a lot
allowed.
of people A lot of people don't realize how much sugar is in our diet in how many forms and how much sugar are in our products that we use, as Chelsey was saying. So I'm sure that was eye-opening. It looks like somebody has a question about MCT and HDL cholesterol. Chelsey, do you want to field that?
Yeah, so there's not, I have found, so I've had a couple kids who have had the high lipid panel and a lot of lipid abnormalities past the 2-year mark. I usually just like wait it out, usually gets better. A small amount of them continue to have some pretty aberrant values. And in HDL, so we know that to be your good cholesterol. I have not found that MCT oil helps your HDL. So typically what our dietitians recommend for kids with a low HDL, and remember that's the one that we want to be high, we recommend more fiber and more exercise. Sometimes we have done like other things of trying to have, and this is just for your lipid parameter in general, we'll say, okay, try more plant-based things, less animal fat stuff. We've tried soy lecithin. I've tried kids on pancreatic enzymes. I think it's all, I've seen some benefit when people change from like, more butter to more of like a coke or like a avocado oil, but I haven't seen, like my clinical experience, I have not seen MCT to be very helpful specifically for HDL.
Looks like there is another question about a particular genetic disorder, SETD1A. I think a lot of the more rare neurogenetic conditions do not have a lot of research about how particular therapies, ketogenic diet and other therapies are, whether they are or are not effective in their condition, just because there's not a lot of numbers. And so, you really kind of have to have a sufficient population to determine whether the diet is going to be more or less effective than what it is kind of across the board in all epilepsies. And so I think it's been really challenging to identify that for rare conditions. I wouldn't see any reason why it would be, less effective at this point based on the mechanism of the genetic condition. And I think we do the ketogenic diet for a lot of kids with neurogenetic epilepsies because there aren't things like surgical treatments, and they tend to be or they can be very intractable. So I would say it's probably worth a discussion with your provider.
Yeah, I've even had kids. So the diet is the first line indication for things like GLUT1 and PDH. Where those are metabolic disorders where your brain can't absorb or you can't make glucose or the correct energy substrate for your brain. And even on classic keto and high levels of ketosis, those kiddos still suffer symptoms. So I think it's interesting how, one, every kid is so different, but even I've had kids with DO syndrome where we see that those are, in those kids, 90% are seizure free on keto. And we've even had a few of those kids with very classic ketogenic diet phenotype, not be seizure free or not really gain any benefit even after 3, 4, 5 months. And so it is, we have tried it in lots of kids, and I don't see obviously a reason why we wouldn't, but even some kids that I wouldn't expect to be great, beneficiaries or great responders to the diet that are, and vice versa. So we will try it in anyone who's failed a few meds. Other questions? I feel like everyone should take a moment and go roast some macadamia nuts and make a pancake. I have not done that one myself. I should though. I do buy ketogenic diet products, and once in a while I'll make ketogenic diet stuff for my keto stuff for my family and be like, let's try it. So I made like a chocolate avocado mousse, and I served it to my husband, and he was like, he ate it and he took a couple bites and he's like, you can't put lipstick on a pig. And I was like, well, thanks a lot, buddy. He was like, it's still an avocado. I was like, but if you put it right, you pretend it's chocolate mousse. And he's like, no, you can't. But I think I did a bad job. I didn't whip it real
well. I know Jen Oliver, one of the other nurse practitioners in the clinic, has gone keto for a month just to give it a try so that she could experience what her patients did. And I know, I think Dr. Joshi, one of our other epileptologists, frequently eats some keto meals. So we have some cooking classes. So I know there can be some good recipes. Sometimes some of them make them into our clinic. So they can be all right.
Yeah, we even did an eggplant refried bean knockoff once. That was not bad.
Okay, nice.
Sadly, I still eat mayonnaise with about everything.
Why not?
I'm
'Cause
not
I know.
surprised.
I had to buy the gallon mayonnaise since I had to consume it
Shoot.
with every meal, and sadly, I still eat it at about every meal.
Why not?
Yeah. Just watch your cholesterol, I suppose.
Yes,
But
that's one reason why I had to come off the diet after 4 years, where it had raised my cholesterol so high.
yeah,
And
it
they
can
didn't let me
be a problem.
go on medication.
I used to eat myself, not for keto purposes, but I used to eat chicken with mayonnaise as a child because I went through a phase where everything had to have a sauce and I had to dip it in a sauce, and so my parents just gave me mayonnaise with my chicken, and I still do it to this day, which many of my people in my family think is kind of gross, but I think it's very tasty.
Why not?
All right, that's enough personal stories about Dr. Park for today. All right, well, thanks so much.
Speak and everything.
Yeah, thanks so much for joining us. We're going to sign off, and then Allie or Lauren, if you want to turn on our little video until we are joined by our last presenter for the day, who will be Dr. Leslie Kay, who I believe is presenting about, one second, neuromodulatory therapy. So most likely RNS, DBS, and other innovative therapies for epilepsy. Okay, thanks so much. Bye-bye, everybody.